Good evening, everyone. Welcome to our webinar on shoulder replacement surgery. My name is Louise and I'm your host for this evening. Our expert presenter is Consultant Orthopaedic Surgeon, Daniel Neen. This presentation will be followed by a Q&A session. If you'd like to ask questions throughout the presentation, please do via the Q&A button at the bottom of your screen. This can be done with or without giving your name. Please note this session is being recorded. And if you would like to book a consultation or find out more information, we have Karen, who will be on the line at the end of the session to talk you through anything you require. I will now hand over to Mr. Neen, and you'll hear from me again shortly. Thank you.
Good evening, everybody. Thank you very much, Louise. My name's Daniel Neen. I'm a consultant orthopaedic surgeon working at Benenden Hospital. And thank you for asking me to talk about shoulder pains, and in particular, shoulder arthritis and joint replacement. So a little bit about myself first. I graduated from London back in 1999 and have gone through my training in surgery, mostly in the southeast of England, in Kent mostly, in fact. I then went off to do some fellowship training, which is further subspecialty training in Exeter and New Zealand, before becoming a consultant at Dartford in 2015. The following year, I started working at Benenden and have been performing reverse shoulder replacements and anatomic replacements, which we'll come on to later on. Since that time, really, it was part of my specialty training. I performed something like 20 to 30 shoulder replacements a year. And so far this year, I've performed 14. And on average, the average shoulder surgeon from our national joint registry is performing about 10. Next, please. So during the session, I will attempt to show everybody a little bit of the anatomy of the shoulder and all the different things that can cause pain in the area. We'll talk a little bit more specifically about shoulder replacements, and in particular, reverse polarity shoulder replacements that not many people have heard about. I'll go on to talk about Equinoxe, which is the particular shoulder replacement that I use, and what to expect when you have the operation itself. We also have a little section from a physiotherapist regarding how they treat shoulder pain. Next, please. Right, so talking about shoulder pain, it's actually a fairly common complaint, with about 14% of people in the country at any one time having shoulder pain. They say an annual incidence of about 1 to 2%, so that's 1 or 2 people per 100 will go to their GP with a new type of shoulder pain. And most of them, and nearly just over 2/3, is all to do with subacromial pain, coming from the tendons that attach. We'll talk about that in the next section. Next, please. So we started off with the anatomy, and what a lot of people obviously have a fair idea about is the skeleton and the bones involved. We talk about the humeral head, which is the ball for the ball and socket, the shoulder blade that we call the scapula, and the socket is part of the scapula or shoulder blade. You then have a little ledge of bone over the top of the shoulder called the acromion, which is actually part of the shoulder blade itself. And coming to meet this area at the front is your collarbone, what we call the clavicle. Next, please. Now, the ball and socket joint for the shoulder is slightly different to hip, for example, in that the socket is far more shallow, it's far more like a saucer. And so the analogy is like a golf ball on a tee. And what this does is it allows a huge range of movement. It's the most mobile joint in the body. But because of this, it's not very steady and stable with regard to the bony configuration. And so the stability of a shoulder really relies on the ligaments and the tendons to help matters. Next, please. So here we have an example of a left shoulder looking at us, and you have the ball and socket again. And on this particular diagram, we've got a couple of the tendons and ligaments starting to be drawn in. And the one in particular that I'd like to show you is the line of the tendon going across the top of the ball and socket there, which goes around the corner and then starts heading down the arm. And that is one of the biceps tendons. There are two biceps tendons, bi meaning two. And so this one attaches to the top of the socket. And this is forming a border for us that sort of delineates the top from the front of the socket itself. Next, please. So we're adding a few more ligaments to this diagram. And in particular, the one at the front there stops the rotation going too far out and is involved in things such as the frozen shoulder that people get, and it becomes inflamed and constricted and will stop movements all the more. There's also the one at the top, which is actually a tendon, and that attaches to the top there to help with the movements going up when you're reaching for things at the top of a shelf, for example. And that is called the supraspinatus tendon and is usually involved with these tears that people develop with time or with trauma. Next, please. So on top of all these ligaments and tendons, we've got the muscles that actually attach to the areas. And there's one in particular at the front that we call the subscapularis, the one at the top that we mentioned, which is the supraspinatus. And there are two at the back called the infraspinatus and the teres minor. They help to rotate the shoulder. And as they work in unison together with these pairings, we call it the rotator cuff. So it's rotating the shoulder. And on top of all these muscles and tendons are the deltoid muscle. And that's the muscle that you can actually feel on the outside of your shoulder. Next, please. So with all these balancing tendons and muscles, they work in unison to balance that golf ball on the golf tee. And if one is damaged or torn, they don't work so well, and there'll be abnormal pull one way or the other. And that can affect the movements of the joint in particular and can cause pain as well at the same time. And as I said, the most common one is the supraspinatus, we call it, or the one at the top, the tendon at the top. Next, please. So concentrating a bit more on shoulder arthritis, just like other joints, the hip and the knee, we do shoulder replacements, and they come in various forms. This one in particular that we're showing now on the right side of the screen is called an anatomic. We call it an anatomic replacement because we are replacing like for like. We're replacing the ball side of things with another smooth surface and the socket with a sort of saucer-like surface. And the idea is to try and replace the painful joint surfaces. We do this particular joint replacement if the tendons are all working well and in unison. Otherwise, it becomes imbalanced and causes more issues than it solves. Next, please. This is a reverse shoulder replacement, and we usually do this when the rotator cuff itself is damaged, so the tendons are torn off or are damaged and not working properly. And the idea is basically to reverse the anatomy so that the socket becomes a ball and the ball becomes a socket. And what you can't see on the X-ray is that there is a bit of plastic in between the two bits of metal that helped the movement of the joint to be smooth and pain-free. You can see with the X-ray on the right-hand side there, that what's happened with this case is that because the tendon tore off, the ball for the ball and socket was allowed to ride up right underneath that ledge of bone that we call the acromion and start rubbing on the undersurface there. So with the reverse shoulder, it holds the arm down underneath the ball and doesn't allow that to happen. Next, please. We call that riding up of the ball underneath that ledge of bone a rotator cuff arthropathy. And it was a term coined by the gentleman in the picture on the screen there, Charles Neer, who's a very famous American shoulder surgeon. And he described this migration of the humeral head up underneath that ledge, causing more and more damage as it goes, and restriction of movement along with the severe pain. He described a near complete loss of function. But fortunately, with a reverse shoulder replacement, you can retain a certain degree of movements. It does depend on how stiff the shoulder is to begin with, but we'd certainly expect to try and help get the hand behind the head or reaching forwards towards at least shoulder height. Next, please. The whole idea of this reverse shoulder is quite ingenious. It was brought up by this gentleman here, Monsieur Grammont, and he started experimenting really in the 80s. But the replacement itself has come on and on over the last few decades, and we're on to the 4th generation of replacement already. The idea being that we place the center of rotation in a different position, we shift the arm bone underneath the ball, and we tension that big muscle that you feel, which is still intact, to give it more ability to do the movements that we want your arm to do. Next, please. So this is a particular implant that I use. It's the Equinoxe system by a company called Exactech. There are lots of different systems out there, lots of different companies. And if you can imagine, they're very much like car brands. They all do the same sort of thing. They're just little tips and tricks that they each use, which they think gives it an advantage. With the Equinoxe system, it's a platform system. And what that means is that basically the stem inserts into the bone of the arm is the same for whichever type of replacement you're doing. This gives the advantage that if we start off with an anatomic replacement, i.e. the ball and socket are the same way round as they should be, should the tendons fail, later on, we can just replace one portion of the joint replacement rather than everything altogether. As you can see, there are different variations of the replacement, but in essence, they're all trying to do the same thing. They're replacing that painful joint surface with metal and plastic so that you retain a degree of movement, but avoid all the pain. Next, please. So what happens when you have a joint replacement surgery? So usually you will come in on the day of the operation itself. And if it's in the morning, you'll come in the very early morning, or if it's in the afternoon, you'll come in the late morning. And that's so the nurses can all do their paperwork and make sure that you're fit enough and ready for the operation itself. You will then also be seen by the anaesthetist and by the operating surgeon themselves, just to go through any final details or points or questions that you may have about the operation itself. The operation is performed under a general anesthetic, and that means you're asleep for it. But the anaesthetist will normally perform a nerve block, which is an injection in your neck to numb your arm up. And the advantage of that is that you wake up without any pain afterwards. The nerve block itself will usually last for about 24 hours, and you should start taking painkillers before it wears off. People tend to stay one night in hospital only with a shoulder replacement as compared to hips and knees, which may be a bit longer. Next, please. We get asked a lot about normal activities, and as I alluded to earlier, it does depend a little bit on how stiff and how long the arthritis has been present in your arm. So if you've lost a lot of the muscle, you'll obviously take a little bit longer to get back to normal movements because the muscle needs to build up strength again. And if your arm is stiffer or particularly stiff, then the movements themselves will be slightly more restricted to start off with. In general, with the preoperative rehabilitation, we aim to get passive movements, and by that I mean moving the arm using the other arm or with some other means other than the muscles of the arm itself by about week 6, and for the active movements to be at least as good as before the operation by the 3-month stage. This means that in general, you'll be looking to start driving from about the 6th week, if you feel confident enough to do so, golf from about 3 months, swimming from about 3 months as well. Lifting things, initially you can start lifting light weights with no problem at all. However, you should avoid having heavy lifting for about the first 6 months until the ligaments, tendons have all grown strong enough that they can support that activity. Next, please. As I said, it's not a new thing, shoulder replacements. This is something called the National Joint Registry, which can be found on the internet. And it's something that the UK have been putting together for a long time. This is the 18th annual report now. And it gathers details of everybody that has a joint replacement in the country that gives consent to have their details recorded. And for shoulders, we've been recording the information about outcomes since 2012. Next, please. Here's an idea of some of the numbers that they've been recording over the years. And obviously, with the last couple of years, with COVID-19 affecting the number of replacements and operations in general that we could perform, and the numbers were diminished. But you can see leading up to COVID, that the shoulder replacements were in the 7,000, whereas hips and knees are going all the way up to 100,000 or beyond. So we do far more hips and knees in this country because it's a very established operation. Ankles and elbow replacements are both joints that we can replace and have started to be recorded on this National Joint Registry. And it's something that will be developed over the oncoming years, I'm sure. Next, please. One interesting fact that's come out of these reports are the proportion of different types of shoulder replacement that we use. So back in 2012, when they first started recording the use of shoulder replacements, about a third of them were this hemiarthroplasties. And the hemiarthroplasties are where you replace one half of the joint only. You leave the socket side alone. About 25% of them were a total shoulder replacement, and that's an anatomic. And about another quarter of them were these reverse polarity shoulder replacements. But if we look at the more recent years, there's been a bit of a turnaround with hemiarthroplasties diminishing in number, because we recognized that replacing the socket side of things actually gave a more reliable, better, longer term outcome. But the reverse polarity replacements have really taken off, and are nearly approaching 2/3 of the replacements that go in these days are now reverse polarity. Next. One advantage, obviously, with all these new technological aspects are the aids to surgery that we now have. And the Equinoxe system is no exception with that. So we can use something called GPS, Global Positioning System. What that means is that I can take a scan before the operation of your shoulder and then plan where I'm planning to put the socket. The angles are all worked out, and it sizes it for me as well. So I can go into an operation with a very clear idea of where I want to put the prosthesis itself, and any potential pitfalls such as little bony protuberances, which may throw me off otherwise. And the other thing is we can take it one step further even and use this special machine that will guide the drill so that I know exactly where I'm drilling, what angle I'm drilling, and place any screws within the bone rather than guessing where I'm putting them. This leads to more predictable surgery, and the thought is that in the longer term will give us a better outcome, but that is yet to be proven. Next, please. Obviously, we've talked about arthritis as the cause of shoulder pain, but there are many more causes for shoulder pain, given how many structures attach and are involved in the shoulder itself. As we talked about the rotator cuff, so if there is a torn tendon, for example, it may be more suitable that we repair the tendon rather than going to try and do something with the joint itself. Frozen shoulder was one of the things we mentioned, with the tightening and inflammation of the ligament at the front of the shoulder in particular, but the whole joint itself can become very inflamed and cause diminished movement and severe pain. And along with injections, a release can be performed to help range of movement in particular. A subacromial decompression is an operation where we shave a little bit of the bone on the undersurface of that ledge of bone that we talked about, called the acromion. And the idea is to increase the room for the tendons to move, to stop them impinging on the underlying tendon itself and causing more damage. And obviously physiotherapy is the mainstay of treatment initially. And we have a physiotherapist who can give us more information about that online with us today.
There are many reasons you can suffer with shoulder pain, and we tend to separate them into traumatic or degenerative. The traumatic reasons could be if you've injured your shoulder doing playing sports, or it could be at work. The degenerative reasons could be that you've got an underlying weakness, or the joint's a bit stiff, or you have have imbalances somewhere else in the body. So it could be neck or coming from your back. Exercises and keeping active can help manage shoulder pain because it keeps your joints supple and it keeps your muscles strong. The shoulder joint, particularly the shoulder joint, requires a lot of strength to stabilize the joint. So it's really important to stay active and lead a healthy lifestyle. You would want to seek help for your shoulder pain if the symptoms appear to be getting worse after 2 weeks, because this is the period where structures become inflamed, and it takes 2 weeks for them to kind of settle back down through just self-management techniques such as taking pain relief, anti-inflammatories, putting ice on the area, and just generally trying to not aggravate the shoulder. Otherwise, if the shoulder pain's been going on for 6 weeks, then it would be beneficial to seek help from your GP, physiotherapist, or consultant, for them to give you professional advice on how to manage the pain. At your first physiotherapy appointment, you'll have an initial assessment of an hour where we would assess the problem, give you an idea of what's going on and how we're going to manage it. We then treat you for as long as you need to get back to your goals. That could be hanging up the washing, that could be playing sports. Once you've achieved your goals, we'll tell you how to manage it from then on and prevent it from coming back in the future. If conservative management hasn't helped in physiotherapy, then we tend to refer the patient onto the consultant for further investigations and for surgical opinion.
Thank you, Mr. Neen. Thank you, that was very interesting. We're now going to a Q&A session, and please do feel free to send over any questions you have, no matter how small they might be. The first question, they say they've been suffering for quite some time with arthritis. Their doctor has previously mentioned shoulder replacement surgery, but they feel as it is a last resort, and should they wait until it's unbearable? Are there risks to not having the surgery and putting it off for longer?
That's a good question. So the whole point of a shoulder operation, shoulder surgery for replacing the joint, is to help quality of life. If pain is affecting your daily activities, despite taking painkillers on a regular basis, stop you doing the things that you want to do, and in particular keeping you awake at night, because night pain can be particularly severe, then it's worthwhile talking through the risks of the operation. All operations have risks. The overall risks with joint replacements are known and documented. With a reverse shoulder replacement, for example, they think the cumulative risk is approximately 6%. So 94% of the time, there are no problems at all. Now, that 6% covers a wide range of things, from something very minor to something more serious. But obviously, we have to balance how badly the pain is affecting the quality of your life versus whether it's worth taking the risk. People say it's a last resort. That's an interesting thing. So I think you should certainly try all other interventions that are less risky first. And then, yeah, absolutely seeing a consultant with regards to talking through whether or not you would benefit from the shoulder replacement would be worthwhile.
Okay, thank you. Okay, our next question. This person is looking at having a shoulder surgery as they've been suffering from shoulder pain for years. It has stopped them from being as active as they used to be, and they'd love to get back into tennis. Would it be too intense to play tennis afterwards?
So there are various forms of surgery that we can do for the shoulder. So it does depend a little bit on what diagnosis we're treating here. But in general, if you're talking about a shoulder replacement, then no, I think once the healing stage is over and the tendons are strengthening up and the muscles and the control of the shoulder is strengthening up, then going back to something like tennis is entirely feasible. I wouldn't necessarily go back to it straight away, most certainly. And you are talking about many months of rehabilitation first. And potentially, as long as the range of movement is acceptable for the use of a tennis racket, which I'm sure it should be, then going back to tennis would be fine.
Okay, thank you. Okay, this person is 62. They have seen the doctor and a physiotherapist many times for shoulder pain. They're worried about having replacement. How long would it last for? And would they need to have surgery again?
Yes, so the one worry with the shoulder replacements is longevity. And the good news is that the latest information that we have from all these different research data that comes in left, right, and center from different countries, not just our own, does look like these shoulder replacements last a good length of time. You're talking about 95% lasting more than 15 years. They do wear out. Unlike a body where you can heal if there's a little bit of damage, with a false joint, that damage potentially can accumulate. The things that hold the joint in place can loosen up, and you can get more wear and tear changes. So with somebody with an anatomic replacement at the age of 60, there's a good chance, in fact, that you may have to have a further operation into your 70s, late 70s, where you are replacing the shoulder replacement itself with a new implant, a second revision surgery. Now, whether that's another anatomic or a reverse shoulder does depend a little bit on the state of the tendons at the time, but it's entirely possible.
Thank you. Next question. This person is 54 and they have a torn rotator cuff. If they had this treated, would the recovery be similar to a shoulder replacement?
Okay, so slightly different recovery time, but a similar process in that you're still waiting for these tendons to heal back in place. The idea of a tendon repair is you are basically pulling the tendon which is pulled off from the bone and can't get back down to the bone itself without a little help. We pull it back into place and hold it in place with some suture material, which is actually made of a plastic. That holds it in place, but is not strong enough to take the full weight of and forces required for everyday activities. And so we do tend to protect the repair while that process is ongoing. And the biology is about 3 months for that to form a strong enough bond that you can start putting force through it. So usually for the first 6 weeks or so, you're in a sling. And then thereafter, we start getting increasing movements and then strengthening exercises in a gradual manner.
Thank you. Last few questions now. This person has damaged cartilage within their shoulder joint and they suffer really badly with shoulder pain. They believe this would be keyhole surgery instead of full replacement. Therefore, would they need to stay overnight in hospital?
Right, so it sounds like they're going to be having something called an arthroscopic, which is the keyhole surgery, debridement, which basically means cleanup of the joint. We tend to reserve that sort of operation for people who have arthritis. Damage to the joint surface is a form of arthritis. And it depends on how large the surface area affected is. But if we don't want to go down the route of a joint replacement, either because the area is very small or they're very young for the operation, then we tend to do this debridement stage. And the keyhole surgery itself is usually a day case procedure, absolutely. And so you wouldn't necessarily have to stay in hospital. The joint replacement itself can't be done through keyhole, unfortunately. It does require a little bit of a bigger incision, usually around 10 centimeters or so at the front of the shoulder.
Thank you. This person, they say, I have needed to have a shoulder replacement for a couple of years, but I've put this off as I'm approaching 80, and so I'm worried about having major surgery. Is age a concern for having this type of surgery, and can it affect my recovery?
So our prime candidates for a reverse shoulder tend to be in their 70s. And so any operation is a concern. And obviously with age come comorbidities, as we call them, which means other medical issues, potentially with hearts or lungs or kidneys. And we do have to take that into consideration when we're planning any major operation. And a joint replacement is a major operation. However, anaesthetists are very aware of all these potential problems. From a surgical point of view, the operation is the same regardless. We have to be a little bit careful if we think that the bones are going to be a little bit more fragile. But in general, the operation technique is going to be the same regardless of age. What I would say is the comorbidity, so from an anesthetic point of view, yes, we do have to be a little bit more careful, definitely with age. And the anaesthetists we use are very careful in explaining to the patient the risks and whether they think that the anesthetic is a good idea or not. And we'd be upfront with that. We wouldn't necessarily anesthetize everybody that needs an operation.
Thank you. This attendee is 56. They've had shoulder pain since they started working from home in 2020. Their GP's physio gave them some online shoulder exercises, but they did not help. The pain is less now, but they still can't raise their arm above their head. Is there anything more that can be done without going down the surgery route? Thank you.
So we saw a huge swathe of people coming in with shoulder pain, started working from home. And I think it was something to do with how people were working, either on their laptops in front of them, rather than on the workstations that you have in the offices sometimes. And a lot of shoulder pain is to do with position and posture that you take, which is why physiotherapy is such a good way of treating shoulder pain in the initial stages. So if you imagine that you're hunched over a desk or your laptop, your shoulders are rounded forwards. And when you're doing that, you're actually diminishing the space between that ledge of bone that you can feel on the outside and the underlying tendons. And that causes a physical pinching, we call impingement. And people are far more likely to develop this sort of secondary effects of this position problem. Irritation, tendinitis, so inflammation of the tendons, inflammation of the cushion that surrounds that area. And so and the other problem obviously is with shoulders, it takes a long time for things to calm down. And it's not unusual for shoulder pain to take a good 9 to 12 months to settle down, which is why, again, we don't leap into surgery necessarily straight away when some of these things will calm down on their own without us doing anything at all. So in terms of other things that you can do for shoulder pain, other than physiotherapy, we can try and help calm down any inflammation with an injection of a steroid. Steroid is not the sort that people use to body build. The type of steroid that we use in injections is a very strong anti-inflammatory. The pills that we take, ibuprofen, naproxen, they're called non-steroidal anti-inflammatories, but the injections we use are steroidal anti-inflammatories. And these injections, they give the drug a 6-week window to work in their area, specifically where it's causing the issue. Physiotherapy, shockwave, acupuncture are all modalities that our physiotherapists can use to try and help calm down the pain without going on beyond into the more sort of invasive interventions, if you like.
Thank you. So that's all the questions we have. So thank you very much for everyone who sent in a question, and thank you, Mr. Neen, for answering them so clearly. Just to highlight on the screen, we are doing 50% off your first physiotherapy appointment and 50% off an initial consultation with Mr. Neen if you book this through our private patients team by the 5th of August. Just need to quote that you webinar on the subject line for that. Karen, our private patient consultant, private patient advisor, is on the line now. If you want to speak to her until 8 p.m, she can advise you and possibly book you in for consultation with Mr. Neen. Alternatively, her team are in the office 8 a.m. to 6 p.m, Monday to Friday. At the end of this webinar, you'll be presented a short survey, and we'd really appreciate it if you could complete that, so it helps guide and steer our future presentations and give feedback to our consultants. Our next webinar is in 2 weeks' time on the 18th of July with Consultant Orthopaedic Surgeon, Mr. Wallace Poon. He will be discussing immediate, effective and safe cataract treatment and the special lenses we provide at our special eye unit in the hospital. So on behalf of myself, Mr. Neen and everyone at Benenden Hospital, I'd like to thank you very much for joining us today. And we look forward to seeing you again soon at one of these events. Thank you. Bye.
Thank you.